All the barricades, I wanna know why they hold me back. Need a miracle to break me through, but I won't get that. If I was a real wonder, then I could save me from turning around, lift me off the ground, and one day I'm free.
Hello, and let's start with the next disease and the next program, that is HIV or NACO program, or the NACP. That is the technical name of this program, National AIDS Control Program. NACO stands for National AIDS Control Organization, and the disease that we will be dealing under this is HIV or AIDS. HIV, I think everybody knows, it's a very newly developed disease. 1986, the first case was seen, and it has baffled all the researchers and scientists. We do not have a cure for HIV. Let's go ahead and talk a little bit more in detail about HIV. And in this module, we are going to talk about HIV per se, plus the targets, diagnosis, and management of this disease. The competencies which are associated with this particular video modules, 2 video sessions we are going to take on HIV. We will try to understand, to learn about the epidemiological determinants of HIV. HIV, why is it a public health problem? The objective strategies of National AIDS Control Program. The community level diagnostic, this is important, diagnostic and management protocols for HIV, which keep on changing all the time. Immunization in HIV, prophylaxis, prevention of HIV transmission, and surveillance or under the National AIDS Control Program. What are the strategies, different types of surveillances? So let's get on and talk about the National AIDS Control Program, or the NACO. I hope you all know this is the red ribbon, and red ribbon is the symbol for HIV or AIDS. Red ribbon is the symbol that is for HIV or AIDS, and the World AIDS Day is observed on World AIDS Day is observed on 1st December every year. It is observed on 1st of December every year. So let's take on the topic number 1 for HIV, the epidemiological features. As always, we are going to talk about the agent factors, host factors, and the environmental factors. In HIV, we do not probably talk about the environmental factors. Instead, we will, like in tuberculosis, we talked about the social factors. Let's talk about the agent factors, beta. HIV virus, it is from the family of lentivirus. It is a single-stranded RNA virus, and this RNA virus is so notorious, it enters into our immune-building cells, that is the CD4 cells or the T helper cells, and they actually take over our genomic mechanism. The RNA will get converted into the DNA through reverse transcriptase, and it takes over the host DNA mechanism. So that's how bad this HIV virus is. A few more points about this agent. For HIV, please note that this HIV could be of 2 types. We can have 2 types of viruses. You have HIV-1 and HIV-2. Which is more common? Please note that HIV-1 is more common. HIV-1 has further subgroups. It has many groups. We have different groups like Group M. These are the groups. Group M, Group N, Group O, and Group P. So P is actually a probable group. So we have a major group, outlier group. It is a neither major nor outlier group, and maybe we also have a few researchers talk about the probable group also. Which of the following is the most common? Of course, major has to be most common. Now, major group further will be having subgroups. It has a lot of subgroups. So subgroup A, B, C, D, E, F, G, H, and till J. So it has a lot of subgroups. So MCQ which can be asked is, which is the most common subgroup? Please note that the most common subgroup is group C. So what is most common type of HIV? Most common type of HIV has to be HIV-1. What is most common? It is the most common. Most common has to be most common, right? So MC, HIV-1 MC is the most common type of HIV. So that is your question number 1 about HIV. I would also like you to know that if we talk about this HIV virus, it is alcohol sensitive. It is ethanol and detergent sensitive. It is sensitive to many solvents. But surprisingly, it is resistant to radiations. It is resistant to radiations. So therefore, when we are talking about HIV virus disinfections, probably the best disinfections would be any alcohol containing disinfectants rather than having a UV radiations or gamma radiations. So that was your question number 2. Question number 3 is regarding the modes of transmission. This would be your like very important 3 by 5 star MCQ topic. Lot of times frequently asked question. So what do you see over here in this screen? You would see different modes of transmission. We can see the efficiency is highest with the blood route. So please note that the biggest chance of having transmission of the HIV is for the blood route. But which of the following is the most effective? So there is something called as effective mode of transmission and there is something called as efficient mode of transmission. Anything which is very efficient may or may not be effective. What do you mean by effectivity? Effectivity means that in the total HIV case load in our country, does a blood transfusion or the blood transmission, does it play the majority of the role? If I give blood to any person, it has the maximum chance, that is efficiency. But out of the total cases, do you know that maximum has sexual mode of transmission? It is 75 to 80% mode of transmission is sexual only. So sexual plays the maximum effective mode of transmission. Blood, perinatal, they all are 5 to 10% mode of transmission. Again, IV drug abuse is 5 to 10% mode. Needle stick is less than 1% mode of transmission. So it is what is important for us to understand which is the most effective route. Please note that the most effective route of transmission is sexual. Most efficient route of transmission is blood transfusion. A little bit more about the transmission, mode of transmission for HIV. What is more chances for a male who is HIV being giving the infection to the female, or is it the female to male? Please note that the chance for male to female is higher compared to the female to male. Why? Because male, there are two reasons to it. Why? Because the male has a higher HIV concentration in semen compared to the vaginal fluid. So one is this. The second reason could be that the female has a larger area of exposure, whereas the male has lesser exposure. So from female to male, the chances are less. From male to female, the chances are higher because of larger area of exposure during intercourse. So please note that during intercourse, a male HIV transmitting to normal female is higher than a female HIV transmitting to normal male. Next is, what about the intercourse? Type of intercourse. Is oral intercourse more dangerous or anal or vaginal? Anal intercourse is always 3 times more dangerous because of more chances of abrasions or injuries. More chances of injuries or abrasions. Anal intercourse is kind of more chances compared to the vaginal. Third is that if the female is menstruating, she again has a higher chance. Because common sense, the blood is there. Fourth, important that in adolescent girls and in post-menopausal female, there is a higher chance of HIV transmission. Why? Probably because the mucosal lining is thinner in adolescent girls. It is not so much mature. And in postmenopausal, again, the mucosal lining of the cervix and all the genital parts, mucosal lining is less. So there is thin mucosal lining is thinner, which causes more transmission. It has better transmission of HIV. So there is a higher transmission of HIV in adolescent girls, especially age less than 15 years. So especially in very early like adolescent girls or in age more than 45 postmenopausal, the mucosal lining will not be as mature as after 15-16 years for a female to have. Then is a sexually transmitted disease if they are present in a female. If a female already is suffering from any sexually transmitted disease, syphilis is there or any genital tract infection is there, so probably there is more amount of T cells over there. Are you getting it? There is more amount of T cells in that area, and because there is more amount of T cells in that area, the chance of transmission actually increases maybe 3 to 5 times. So there is a much higher chance of transmission. If there is transmission, if there is ongoing STD at that current time of intercourse. Why? Because the T cells or the immune cells which are going to be affected with HIV, they are already there. So that causes more chance. Last is about the window period. What do you think about the HIV transmission during the window period? Please note, it is highest during the window period. Why? Because during the window period, the blood is going to have the HIV virus and the antibodies have not formed. And because antibody not formed, that is why we call that as the window period. So the HIV viral load is usually highest during the window period. So because the viral load is at the maximum, that is the reason the chance of transmission is maximum. It is high during the window period. Don't answer ulta. So please note that during the window period, the viral load is high. Viral load is higher compared to the antibody load. So that is the reason more transmission can happen. So please note that more transmission in case of male to female, anal intercourse, menstruating female, and also in postmenopausal and so on. Another MCQ which has been asked quite often is regarding the needle stick injury or between the healthcare professionals. So please note that the chance of needle stick injury is very less efficient and it is not a major source of HIV transmission caseloads in the community. So another MCQ which can be asked beyond this is about HIV transmission through urine or through saliva. Please note that it is very low. The viral load is almost negligible. It is very low in urine. Remember, very low in urine and almost absent in saliva. So it is almost absent in both of these. If you're going to mark one answer, you can mark urine because it is almost negligible there. But in saliva, the viral load may be present, which is actually deactivated by many salivary enzymes. So please note that blood is the highest mode. It is the most efficient. Sexual is the most effective. Perinatal is again important. Perinatal causes 20 to 40% chance, but in community, it is only 5 to 10% effectivity. Then you have urine and saliva. They do not transmit mosquito bites. They do not transmit HIV. And male to female is more than female to male. Next is nothing very special, talking about the host factors. What is the most common age for HIV? Usually it is said that age more than 20 years. So 20 to 50 years is the peak age for HIV and there is no gender predilection, like it is equal in females to males because usually sexual route is the mode of transmission. Social factors, yes, it is important from HIV point of view. It is a social discriminated disease. It is kind of a hidden disease. So it is not openly available in the public, and that is the reason to combat a disease which is not socially acceptable disease, it is a different task level by the government system. So very slowly, I'll talk to you that how to tackle this disease from the public health point of view. But anyways, point of view to understand it is a social, there is a disease. The HIV has social discrimination. It is specifically found in some occupational groups. It is more in high-risk occupational groups. For example, it is more in commercial sex workers or prostitutes. It is also more in truck drivers. It is more in male migrants. So it is also more in intravenous drug abusers. So these are the high-risk groups. I hope everybody understands about the social factors. So there are environmental factors, which are the social factors, host factors, and the agent factors for HIV. So now, before I talk about the HIV program per se, I would like you to understand a little bit one point about HIV. I know you must have done much in detail in medicine sessions, but one point about HIV from community point of view, that how do you find HIV? So HIV is taken in different stages. We can have stage 1, stage 2, stage 3, stage 4. So when a health worker or any nurse or even doctor working at a PHC level, they would be probably thinking about HIV, they need to understand this. So at the stage 1, it is usually asymptomatic. The patient is asymptomatic. The CD4 count is OK types. Usually normal CD4 count would be anything more than 1000, right? So the CD4 count would be OK and asymptomatic, or max the person might have a generalized lymphadenopathy. In the stage 2 of HIV, now the patient will start having some infections. So usually these are called as surface infections. These are usually the mucocutaneous infections like oral candidiasis, oral candidiasis, some dermatitis will be there, something will be there on the body, nothing very special. But in stage 3, now the serious thing starts. So stage 3 onwards, it is kind of serious HIV. At stage 3, the CD4 count will be low. And now there is happening of the deep tissue infections. There is deep tissue infection. So I'm just giving you an overview beta. Of course, in detail, you'll study during your medicine sessions. But there is in stage 3, there is a deep tissue infection. Like, for example, some organ involvement will start happening, like the liver, hepatitis will be there, pneumonias can happen, pancreatitis can be there, things like these. So deep tissue infections like hepatitis or pneumonias can happen. And then in stage 4, you have massively big infections, dangerous infections, which are the opportunistic infections. And we can also have malignancies. MCQs on this now. First MCQ, which is the most common opportunistic infection in HIV? What do you think is the most common opportunistic infection in HIV? Please note, do not answer any other infection except tuberculosis. Pulmonary tuberculosis is the most common opportunistic infection in HIV. In which category does pulmonary tuberculosis fall? It unfortunately does not fall in stage 4. It is stage 3. So pulmonary tuberculosis is in stage 3. That is why I am telling you these are MCQs. These are exceptions. Pulmonary tuberculosis is stage 3. It is the most common opportunistic infection. Next in line, all other opportunistic infection like the pneumocystis jirovecii infection, the CMV retinitis, toxoplasmosis, everything, cryptococcal infection, everything is all opportunistic infection, right? So extrapulmonary tuberculosis, which stage? Please note that extrapulmonary tuberculosis will be stage 4. Pulmonary tuberculosis is stage 3. Next in MCQ over here about the malignancies. Which is the most common malignancy? Most common malignancy in HIV? Please do not answer. Unfortunately, the answer is Kaposi sarcoma is not correct. Unfortunately, Kaposi sarcoma is not correct. Most common malignancy in HIV is a non-Hodgkin lymphomas. Non-Hodgkin's lymphomas are the most common malignancy in HIV. Please note that Kaposi sarcoma is a very rare cancer. Kaposi cancer or Kaposi sarcoma is a rare cancer, but it has the strongest association with HIV. So Kaposi is strongest association. You see Kaposi sarcoma, think of HIV. A person has HIV, think of non-Hodgkin lymphoma. Which is the most common opportunistic infection? It is pulmonary tuberculosis. It is very, very common in HIV. So now let us get together and talk about this brand new program, that is the NACO, National AIDS Control Organization, which started the NACP. NACP stands for the National AIDS Control Program. National AIDS Control Program. MCQ number 1. It's a very brand new program. It was started in year 1992. So just to show you the timeline, you don't need to memorize anything. Just note that the first case which came was first case reported in India was in 1986. And subsequently, so fast, within a matter of next 6-8 years, the NACO program was launched as phase 1, phase 2, phase 3. And phase 4 of the NACO program. So NACP, it was launched as phase 1, phase 2, phase 3, phase 4. Recently, in year 2017, we started with the National Strategic Plan to end HIV. So National Strategic Plan to end AIDS epidemic. It was launched in year 2017 till 2024. So whatever guidelines I'm discussing with you right now in the video, it is all based on the NSP. We talk it as NSP 2017 to 2024 guidelines. So this is what we have in the program right now. So that is what you need to understand. It was started in year 1992, but we have now is the National Strategic Plan, which is going to end till 2024. Next MCQ. This National AIDS Control Program, beta, it was started in year 1992 as a vertical program. It was started as a vertical program. Please mind the word, it was a vertical program. Now it is no more there. Vertical program. What does it mean? See, Ministry of Health and Family Welfare is there. They will have the system with them, PHC, CHC, district hospital. We did so many things in National Health Mission. Now the NACO program that was launched under the health minister only, not with the machinery, it was taken as a separate vertical. So it was taken as a separate vertical program, of course, under the health ministry. But now it has been merged with the National Health Mission or the Health Ministry system in year 2021. It was merged. So no more, it is not a vertical program anymore. But if you read the old books, they will say that which of the following is a vertical program. MCQ, they'll ask you very fondly. Answer would have been a NACO program, which now this MCQ is irrelevant. Please note that this was a vertical program. Just a few, it's not actually a MCQ because by the time probably you'll be watching this video, probably it would be very late or you would have had a next World AIDS Day. So when do we have the World AIDS Day? When do we observe the World AIDS Day? Please note it is observed on World AIDS Day is on 1st of December, December the 1st every year. So the theme for the World AIDS Day in year 2021, it was to end inequalities, end AIDS and end any kind of pandemic because we had suffered with that COVID-19 pandemic. So that is about the World AIDS Day. Next, let us talk something more serious in business about the targets of the NACO program. Now, let us talk about the target. The first target beta that you need to do is something called as the WHO's 90-90-90 strategy. What do you mean by 90-90-90? The WHO says that out of all HIV infected people, out of all HIV infected persons, it is said that 90% should be diagnosed. Out of all the HIV infected people, the population, 90% should be diagnosed. The second 90 is that out of all the 90% who are diagnosed, out of all HIV diagnosed, 90% should be treated, should be on treatment. So 90% out of all the HIV people should be diagnosed. Out of diagnosed, 90% should be treated. And the third 90 is that out of all the people who are on treatment, out of all HIV treated persons, 90%, at least more than 90%, should have a viral load decrease, should have a response to the ART which is available. So your drugs should be good. That is what is this 90. And the treatment availability capacity should be good. That is what is the second 90. And the diagnostic should be good. That is your first 90, right? So 90% out of all HIV should be diagnosed, 90% should be put on treatment, and 90% should have a good viral load decrease. So this is what is the 90-90-90 strategy. The second strategy which was given by WHO, I'll come to the targets, but you need to know the WHO targets. So the second thing that they started was the treat all strategy. What do you mean by the treat all strategy, beta? That means irrespective of the CD4 count. Irrespective of the CD4 count, you give ART. So ART is now universal. Everybody gets ART. Any person with HIV will get ART. Now, if you have understood this, now it is easy for me to tell you what are the targets. Let's move on to the discrete targets now. You already know, point number 1, that the WHO target is what? 90-90-90. Okay. The Sustainable Development Goals. What is SDG? SDG stands for the Sustainable Development Goals. The Sustainable Development Goals, they made a different target. The Sustainable Development Goals made a broad target. They said that we have to end HIV and AIDS epidemic. HIV and AIDS epidemic by year 2030. Why? Because SDG was formed in 2015. It was happening till 2030. So everything in SDG is 2030, right? So very simple to understand. So SDG gave us a very broad goal that end this HIV and AIDS epidemic by year 2030. Now the NACP, they wanted to have the discrete goals. So this is what will come in your exam in case it is supposed to come. One is WHO strategy, that is very important. Next is this strategy. This is the NACP targets. What are the targets under our NACP program? Our NACP program says that we should have more than 80%, very important target, more than 80% reduction in HIV incidence by year 2024. Why 2024? Because the National Strategic Plan is till 2024. So this is as per the National Strategic Plan. Just now we talked about the NSP. National Strategic Plan started in year 2017 till 2024. So what is the target? We want to have more than 80% reduction in the HIV cases compared to what? 80% reduction we want to have, but compared to what? Compared to the 2000. Compared to 2010 cases. So that is the baseline. The 2010 is the baseline. We want to have more than 80% reduction in the incidence of HIV. Second, so that is one. Second target that we have under the National AIDS Control Program, the National Strategic Plan, is to have the 95-95-95 strategy. So we want to have 95% people diagnosed, 95% treated, and 95% cure rate or the viral load decrease. I hope you understand. So it is primarily like over enthusiasm of the WHO target. WHO target is 90-90-90. Beta, in your exam, I don't think somebody will ask you about the 95-95-95. If you can remember, very nice. But if you cannot, for your exam, beta, this is super duper important. This is super important. I think this you already know. SDG wants everything to be done by 2030. So these are the three targets you would like to remember for your exam. Next is, before moving to the strategies, next topic I would like to talk to you is about the statistics about HIV epidemiology in India. How much is the incidence of HIV? Please note that the incidence is 5 new cases which happen per lakh population per year. What is the prevalence? So now, do we know the prevalence of HIV? Exactly, answer is no, because there are so many people who would not even know they have HIV, and there are so many people who do not come to the government system to take HIV drugs. So what is the prevalence, exact prevalence of HIV? We do not know, but yes, we do know that the prevalence of HIV in among ANC females in the serosurveillance. We conducted a serosurveillance. Very soon we are going to talk detail about it. So we conducted a serosurveillance just recently in 2016-17. The prevalence of HIV among the ANC attendees over there was found to be 0.22% prevalence. So this actually is taken as the ANC females, they are taken as the proxy indicator. They are taken as the ANC female is taken as the proxy indicator for HIV prevalence in the country. So why? Because we'll talk about it in detail about the HIV serosurveillance, but I just wanted to share the statistics with you that the prevalence of HIV approximately in the country among the ANC females is 0.22. The incidence is 5 cases per lakh population per year. So now coming over to topic number 3 is, what are the strategies in HIV? We already have talked about the targets. To accomplish those targets, you know, the targets are the 90-90-90 strategy, or to end HIV by 2030. What are the strategies? The first strategy is to diagnose HIV early. Diagnose HIV early in stage and properly manage the HIV. Why? Because there is no treatment or cure for HIV. But what we can do is we can give some of the antiretroviral therapy drugs, and these drugs are going to manage HIV. They will keep the CD4 count at a certain level, below which they will not allow it to fall. So how to diagnose HIV? That is our first topic right now. If you talk about the diagnostic modality, beta, we can either have a screening test, we can always have a screening tool, or we can have a confirmatory tool. The various tests which are available with us for the screening tools are the ELISA test, or we can have the other test. These are the rapid tests. The ELISA test is one test, or we can have other types of tests, immunochromatography test, immunoconcentration methods, or the dot blot methods. We can also have the particle agglutination test. All these are rapid tests. So what we do these all are the screening tests. Then we can also have the confirmatory test. Confirmatory test would be like HIV, DNA, RT-PCR, or the qPCR, viral isolation, and P24. So let me just first come to you and talk about the screening of HIV. Screening of HIV. Please note that first MCQ, where do you do screening of HIV? Where will you send? Will you send that patient to hospital A? Will you send it to hospital B? Will you send it to clinic A, clinic B? Will you send it to the neighbor's laboratory? Where to send that HIV? If you are a doctor working in India, where will you send the HIV patient? Please go where? Go to PHC, CHC, go where? We have established something called as the ICTC centers under the NACO program. What are ICTC centers? This is called as the integrated counseling and testing centers. These are the integrated counseling and testing centers that we have, ICTC centers. So in these tests, we are going to do screening of HIV. MCQ number 2. What do you mean by screening of HIV? Beta, we do 3 tests. We do ELISA test, a rapid test, and a spot test, different type of test, that is a spot test. So 3 different tests will be done. So this is done as triple screening, 3 test screening. Screening for HIV is done using 3 tests. What are the tests? We do the ELISA test, rapid test, and a spot test. ERS testing is done. So please note that out of these 3, which is the most important? The first test that we always do is ELISA. ELISA test is the most sensitive test for screening. ELISA test is the most important test for screening. It is the best screening tool that we have. Out of this, now comes the next question. Out of this, if we are doing ERS, out of ERS, please note that if you are doing screening, please try to understand that I'm trying to explain to you that how to diagnose HIV or to how to screen for HIV. So the first situation is that when will you do screening? Have you ever donated blood? If you have ever donated blood, that in that blood transfusion, before the blood transfusion, before you donate your blood, don't you think they will give you a form and they say that we need to check the blood for HIV? So please note that in case the blood is coming to the ICTC or ICTC is collaborating with the blood transfusion department for blood donation services, then any one positive out of this ERS, any 1/3 if it is positive, it is labeled as HIV positive blood and it is discarded. I will come to you again on this point. It is discarded. Next is, in case the patient is symptomatic. What do you mean by symptomatic? Symptomatic means any problem, any infection, any opportunistic infection, any cancer, any type of HIV related disease. So that could be like, what are the symptoms of HIV? The patient could have persistent diarrhea. The patient could have a chronic kind of fever. The patient could have severe, moderate to severe, it could be moderate also, moderate to severe weight loss. So these are like some of the features for HIV or AIDS, and if they are present, or in case there is any opportunistic infection or any cancer, something like that. So symptomatic for HIV. So if the patient is already having symptoms for HIV, then any 2 positive out of 3 will be called as HIV positive. What do we do to this HIV positive beta? We send this patient for confirmatory test. So this is called as a HIV probable case and this is sent for confirmatory. Now third scenario, let us say that there is a person who is asymptomatic. What do you mean by asymptomatic person? Asymptomatic means the person, he or she will not have any features of HIV, no weight loss, no chronic diarrhea. Maybe it could be the ANC female. We are checking HIV testing in every ANC. You remember in MCH chapter we did. Or it could be any volunteer who is coming. So any person who is not having features of HIV, could have any other disease, but not HIV, and that is asymptomatic. So for asymptomatic beta, if all 3/3 are positive, then in that case, we label this patient as HIV positive and we send it for the confirmatory test. We send this patient for the confirmatory test because HIV screening is just a screening. So we do ELISA test, rapid test, and a spot test. So what are the tests that we have in HIV? We can test for any of the 3. The particle agglutination test, the immunochromatography, the immunoconcentration, or the ELISA test. Which is the most important test? ELISA test is the most important. It is the most sensitive test. Coming over to the confirmatory test. Please note that there is HIV virus is a RNA virus. So what we can do is we can have the polymerase chain reaction, the real-time polymerase chain reaction test. So we can use the HIV DNA component. Please note it is the HIV DNA component. This is the investigation of choice for HIV finding in children. In children, it is the investigation of choice. Confirmatory investigation. Next in line is qPCR HIV. What is this qPCR HIV? It is done for adults. It is nothing but a quantitative PCR testing for HIV-1 virus. We can also do viral load isolation or viral load estimation or the viral isolation, or we can have a novel test, that is the P24 antigen test. There is another confirmatory test, that is the Western blot. Please note that Western blot is used in the program. Western blot is the most important. Western blot is the most important confirmatory test. It will test for what? It will test for the DNA, RNA, or the protein. Please note Western blot will test for the protein component of the HIV virus. I hope we all know that RNA is tested by northern blots. Northern blot is for RNA. You know that southern blot is for DNA, and you know that Western blot is for proteins, and you also know that Eastern blot is for enzymes. So you can just remember this. It's like a north, west, south, east, and roti in north, dosa in south. You have more protein in the west, and E for enzyme, E for Eastern blots. So that's just a very simple way to remember. Please note that Western blots, they are highly specific tests. They are the confirmatory test of choice for diagnosing HIV in India. So what we use over here for diagnosis of HIV is Western blot. Now, what about the qPCR? So this is a specialized PCR test which is done only in cases where the suspicion is pretty high and the Western blot is not able to give us a definite answer. Where do you do the RT-PCR for DNA, HIV DNA? That is done only in children, usually for age less than 1 year. So it is done for infants only. For age less than 1 year, we will do a HIV DNA RT-PCR. What about this viral isolation and viral load estimation and the CD4 count? Talking about the CD4 count. Please note it is a very reliable test to assess the response to treatment. It does not tell you whether the HIV is there or not there, or confirmatory test or screening test. It is only used for response to treatment. A better test for response to treatment is best done by directly you see the viral load is best by the viral load estimation. The quantitative viral load estimation is the best for response, but usually CD4 count is a very good clinical, it is a good clinical and a reliable marker to assess the response to ART and about the progression of disease. So that is the only relevance of CD4 count. Please note that CD4 count are neither diagnostic, nor they are confirmatory, nor they are the screening tool of choice. But CD4 count is always done to assess the stage of the disease, how the patient is responding. I hope you remember we already did this 90-90-90 strategy. What is the last 90 beta? What is this last 90? I told you about this last 90. Last 90 is that out of the total 90% who are put on treatment, 90% should have a decrease in viral load. How will you estimate the decrease in viral load? How do you think? We cannot estimate decrease in viral load using the Western blot or the qPCR or the HIV DNA. The only way is to test is viral load estimation or the viral isolations. So directly by the culture techniques, that is the ideal test to find the viral load decrease. So the next strategy number 2, is to have good management of HIV or better care, support and treatment services. So what are the treatment services that we have for HIV? Please note that in year 2021, the government of India was very happy to declare that they had integrated a new drug into the regime, that is dolutegravir. So the regime of choice, this is the first line preferred regime. So now we have for every person, there is a first line, there is a second line. In the first line, there is a preferred regime and there is a alternate first line regime. So there are four regimes actually now. You have a first line and you have a second line. In the first line, you have a preferred and alternate regime. So the preferred regime now for HIV adults is TDF plus 3TC plus DTG. What does TDF stand for? Tenofovir plus 3TC. 3TC is lamivudine plus dolutegravir. DTG stands for the dolutegravir. So it is very simple. Please note that the preferred regime is TDF 3TC plus dolutegravir. It is given as a fixed dose combination, FDC. You remember FDC? FDC is fixed dose combination. We also gave fixed dose combination in malaria. We gave FDCs in tuberculosis. So FDC is used also in HIV. We give tenofovir, lamivudine and dolutegravir, and it is one of the preferred first line agents. The alternate agents, if you want, you can remember the first line, the second line, but please note the preferred you should remember for children and for neonates. The preferred regime for children now is abacavir plus 3TC, that is lamivudine plus dolutegravir, and for neonates we cannot give dolutegravir. Instead of dolutegravir, you replace it with lopinavir, ritonavir boosted combination, or still the preferred drug is raltegravir. So the full form of all these abbreviations that I have written are here on the screen, but I would like you to remember the preferred dose for adults, for children and for neonates. Please note these are new additions now. This is what is a new update. Dolutegravir is into the game now. Raltegravir is into the game now. And for all children, the preferred regime is abacavir plus lamivudine plus we have is the dolutegravir. So this is what is the FDC for HIV, and it has to be taken lifelong by the patient for maintaining the viral load in his or her body. Now coming over to the next point, please note this is typically 3 by 5 star MCQ topic. Point number 3, what is this prevention of mother to child transmission? First MCQ beta. This is called as prevention of mother to child transmission, prevention of MTCT guidelines. Whenever a child is born to a female who is pregnant, and of course she was pregnant and who had HIV. So to that child, we call that child is HIV exposed. Child exposed to HIV. So for my ease, I will write child exposed to HIV. Okay, child exposed to HIV, this is a small abbreviation I will be using. But what do you mean by a child exposed to HIV? That means the child was born and the mother was HIV positive. So now what are the MTCT guidelines? Let us have a look at some of the MTCT guidelines. First point is that let us say a child is exposed to HIV. What are you going to do to this child? The first thing that we give to this child is nevirapine. Nevirapine. So nevirapine is first MCQ, that is the drug of choice for prevention of mother to child transmission guideline. So nevirapine is drug of choice. How do you give nevirapine? Next MCQ. Nevirapine is given at the dose of 10 milligram for the child, and it is given once daily. Once daily. It is in the syrup form, right? So it is 10 milligram nevirapine given once daily, and it is given for 6 weeks. So these are two questions we have discussed over here. Question number 3 on nevirapine, still on nevirapine. So now let us say we are supposed to give nevirapine to the child. Before giving nevirapine, you already know that nevirapine standard we are giving is 10 milligram for 6 weeks. Before giving nevirapine to the child, you have to ask the mother that, Amma, did you take HIV drugs? Because she was pregnant and she had HIV. That is the why we are saying the child is exposed to HIV. So we should ask the female, did you take ART? So did she take ART in her pregnancy? Yes or no? If she says yes, then we have to ask very important question that did you take a nevirapine based drugs? So that means that we have to ask her that her prior ART, which was given, antiretroviral therapy, which is given for HIV, was it including nevirapine based ART? Was she taking a nevirapine based ART during her pregnancy? I already know that we are giving her tenofovir, lamivudine and dolutegravir. Earlier we were giving tenofovir, lamivudine and efavirenz. That is the first line. Within that the preferred and the alternate. sometimes the females may not like efavirenz, so they might be given some nevirapine or something like that. So in case we have to ask her about the nevirapine, in case the female says that yes, I was taking nevirapine based combination, in case the female says yes, that she was taking nevirapine based combination, in those cases, beta, we have to replace nevirapine. Nevirapine will not be given to the child now. Now you have to give to the child zidovudine. We give to the child zidovudine. Very important MCQ. We give to the child zidovudine. So why we give to the child zidovudine? Because the mother was taking a nevirapine based combination. Why on earth is the problem? So why do we change nevirapine to zidovudine? There is beta something called as archived resistance. There is something called as archived resistance. What do you mean by this archived resistance? What happens is that if this is the HIV virus, you give nevirapine based regime, there are some viruses, very few, some of the viruses will develop resistance to the nevirapine. Now the rule of God, the natural selection model is that the bigger things will overpower the smaller things. So now the normal looking HIV virus, which already is fast replicating, they overpower the mutated nevirapine resistant viruses, but the resistance gene, it stays archived inside the new virus also. So now in the next progeny, in next child or in next another person, if you give nevirapine, that nevirapine is not going to act. Why? Because there was a nevirapine based resistant gene inside the HIV virus. So the HIV virus, that's why it has baffled many scientists. Why? Because it has a immense capacity to mutate, and it has immense capacity to hide that mutation. So there is a nevirapine based archived resistance. Archive means you put your emails in archive folder, right? We have archive folder. Similarly, HIV virus has an archive folder. So they keep the nevirapine resistance there. So once we are giving nevirapine, we don't give it again. Please remember, we replace it with zidovudine. Let us come to next question. Question number 3. We are still on this problem. We are still on this nevirapine. Before giving nevirapine to the female, we should also ask her that, Amma, did you take ART before? If she says nevirapine, we replace it with zidovudine. Another MCQ that you have to, another question, not the MCQ examiner will ask us, right? So another question that we ask to that female is that, Amma, did you take ART? If she says that, yes, I took ART and the ART I had been taking all through my pregnancy, that means she was taking ART for more than 4 weeks. If the female was taking ART for more than 4 weeks, we call this female as a ART sufficient female. This is called as ART sufficient female. And in case this female is ART sufficient, then you give a standard dose of nevirapine for 6 weeks, or you give zidovudine if she was nevirapine based combination. Are we okay? Now the problem starts. Now in case the female says that no, I was not taking ART properly. In case the female had taken ART for less than 4 weeks. In case the female had taken ART for less than 4 weeks, to this female we are calling it as ART insufficient female. This female is called as ART insufficient female. So now to this female we need to assess something. So what do we assess? To ART insufficient female, ART insufficient female, what are we going to do? To this child who is born, we need to assess whether the child is at high risk of HIV acquisition, some high risk delivery happened, or the child is not okay, or the mother is not okay. Is there a high risk? Is there high risk for HIV for the child? Is there a high risk of acquisition of transmission of HIV? Or there is no high risk? No high risk for the child. In case there is a high risk, now beta please note that we need to give nevirapine plus the zidovudine combination. We need to give the zidovudine plus nevirapine combination. This is given for 6 plus 6 weeks. It is given for 12 weeks. It is given for 6 plus 6 weeks, nevirapine plus zidovudine in case of high-risk babies who are born to ART insufficient females. In case of no high risk to the child, now you are free to give, and the female is ART insufficient, now you are free to give only nevirapine, but this nevirapine is again extended for 12 weeks. So please note that in ART sufficient, we give for 6 weeks. In ART insufficient, we give it for 12 weeks. In case of high-risk baby, you add zidovudine to it. Another point is that you need to replace zidovudine in case the female was taking nevirapine-based combination. So that's all about the nevirapine. Now let us say for 6 weeks, you are going to give to the child nevirapine. All problem solved. Lot of MCQs discussed. Now let us say this baby born to HIV positive mother, the baby takes nevirapine for 6 weeks. What are you going to do? You did not check about HIV till date. Why? Because there is always a window period. Why? Because there could be some antibodies over there in the blood. So now, when will you check for HIV? Please note that once you are done with the nevirapine, 6 weeks, after 6 weeks, please write it down, after 6 weeks. We do Eid. We do Eid. What is Eid? Eid stands for Early Infant Diagnosis. We do Eid, early infant diagnosis. What is early infant diagnosis? What is the investigation of choice? You tell me, I'm not going to tell you. What is the investigation of choice for hair? We already did it just 2 minutes back. We did it. What is the investigation of choice, beta? Investigation of choice for children, I told you, less than 1 year. What is the investigation? It is HIV, DNA, RT-PCR testing. No Western blot, no quantitative PCR testing. We do HIV, DNA, RT-PCR. That is done at 6 weeks. Unfortunately, what if the child is positive, or happily the child is negative? If unfortunately the child is positive, what are we going to do? Common sense, we are going to start ART because the child is unfortunately positive. So give the ART child the neonatal therapy. You remember raltegravir based combination. So you give the neonatal based ART to the child, and in case it is a negative, so you do follow-ups. Usually the follow-ups are done every 6 monthly, but that of course depends on the status of the child and of the mother also. So that's all that you have for the mother to child transmission about the child exposed to HIV. That is the child born to HIV female. We need to give nevirapine for 6 weeks. Then we are supposed to do early infant diagnosis, for which the investigation of choice, HIV DNA PCR testing, and we will give ART in case it is positive. In case it is negative, you keep on following up for 2 years. You keep on following up till 2 years. 6 monthly follow-up are done. Of course, which depends on lot many factors. These are the questions that you get on mother to child transmission prevention guidelines. Next is a related topic. Topic number 4 is, what about the breastfeeding? You already know that there was a child exposed to HIV. To this, you were giving nevirapine, and then you were doing Eid. When were you doing Eid? At 6 weeks. And then this patient is positive or negative. What about the breastfeeding? In case the breastfeeding is continued in this person, or the child is there and the breastfeeding is there. So please note that in case the child is positive, HIV positive, in case the child is HIV positive, please note that the breastfeeding is continued. It is continued. It is advised to continue breastfeeding for at least 2 years. Please note that if the child is positive, the breastfeeding is continued till 2 years, and in case the child is HIV negative, or on follow-up, sequential follow-ups, the breastfeeding should at least be continued for 1 year. Common sense, I understand, I know that breast milk may have some traces of virus also. So breast milk is not clean. Breast milk has a chance of transmission of HIV. But the problem is that if we don't give breast milk to the child, what is HIV? HIV is immunodeficient status. If you do not give breast milk to the child is invariably going to die because of some super added infections. It's not about US or Canada we are talking of. We are talking of a rural country or developing country like India. So in India, we are going to give breast milk to this child. Why? Not because of a risk of HIV transmission. It is because to save the child to infections, because breast milk is going to have lot of immunoglobulins. So please note that breast milk is always given to the child. It is for 2 years if the child is positive, for 1 year at least if the child is negative. Also with the breastfeeding, it is said that abrupt stopping of the breast milk should always be avoided. We never do abrupt stopping of the milk, and we also never change the type of milk from buffalo milk to cow milk to human milk to other types of formula milk. Especially talking about the formula and the breast milk, the abrupt changes should not be there. There should be slow changes. So these should always be taken in caution, that these actually promote HIV transmission with the breast milk. Next is point number 5. What about the prophylaxis of HIV? In case of needle stick injuries, what is the post-exposure prophylaxis, PEP? Many students get confused that, sir, what is PEP? PEP stands for post-exposure prophylaxis. The person has got an injury and you want to save that person from getting a disease. What level of prevention? It is a primary level of prevention. It is a primary level of prevention. What is the treatment regime or the prophylaxis regime that we have? What is the prophylaxis regime that is being offered? So please note that in Government of India in year 2021, in June 2021, this document was released, which happily said that we are very proud to say that now in India we have a dolutegravir based PEP regime also. What is the ART that we are giving, beta? It is tenofovir, lamivudine and dolutegravir. What is the PEP you can see over here? It is same answer, tenofovir, lamivudine and dolutegravir. So please note that the preferred regime as per the NACO program now is tenofovir, lamivudine and dolutegravir for PEP. The alternate regime is that in case we don't have a TLD regime, you can give a TL, that is tenofovir, lamivudine plus a lopinavir, ritonavir boosted combination. Or we can give our earlier we were giving that TLE regime. You remember? Tenofovir plus lamivudine plus efavirenz. We used to give tenofovir, lamivudine, efavirenz. That can also be taken as the PEP. But which is the preferred drug? The preferred drug that you see over here is tenofovir, lamivudine and dolutegravir. So the things have become simplified in HIV and also simplified in tuberculosis now. So now the PEP regime is same. The PEP regime is same for HIV. In case of needle stick injury, we give 3TC, that is lamivudine. We give tenofovir, that is TDF, plus we also give dolutegravir, DTG. This has to be started within 2 hours of exposure, as early as possible. It should be started within 2 hours of exposure and it has to be continued for 28 days. It has to be taken as once daily fixed dose combination, single tablet taken as once daily, preferred during the night time. So this is what is the treatment for post-exposure prophylaxis, your point number 5. Coming over to the point number 6. What is the prophylaxis for tuberculosis? We already did much in detail about the prophylaxis for tuberculosis. Please note that all people, all means everyone, all people living with HIV will get a prophylaxis for tuberculosis because HIV is a very high risk thing for tuberculosis. So what is the drug of choice we give? We give isoniazid to all children who are age 1 year till 10 years. We are giving at the rate of 10 milligram per kg body weight isoniazid. We are giving isoniazid. Plus, we are also giving pyridoxine. Pyridoxine at the rate of 25 milligram tablet. In cases of adults, we are giving isoniazid INH at the rate of 300 milligram. Plus, we are giving a pyridoxine. Every time isoniazid should be given always with pyridoxine. So, we are giving pyridoxine at the rate of 50 milligram. This has to be given for 6 months. It has to be given for 6 months. It is plain simple isoniazid prophylaxis for all TB cases. So that is about the point number 6. Point number 7 is again another prophylaxis that we have for HIV is regarding the PCP prophylaxis, that is pneumocystis jirovecii infection. Beta, for the pneumocystis jirovecii infection, when do we start this prophylaxis? If the CD4 count is less than 350 cells per millimeter cube, or if the HIV or the AIDS stage 3 or stage 4. Stage 3 or stage 4, in those cases, we need to start immediately the PCP prophylaxis. What is the PCP prophylaxis? What is the PCP prophylaxis? We are going to give a double strength cotrimoxazole tablets. What is cotrimoxazole tablet? I think everybody knows that is the TMP SMX. What is TMP stands for? Trimethoprim and sulfamethoxazole. Sulfamethoxazole is given in the dose of 800 milligrams. It is a double strength beta. And trimethoprim is at the dose of 160 milligram. It is also double strength. So this is what we give as the PCP prophylaxis double dose, double strength of cotrimoxazole prophylaxis. When is it started? CD4 count less than 350 and or HIV and AIDS stage 3 or stage 4. So common sense, can you think and tell me? Many times students ask me this on social media. I say it's common sense. So when do you stop this prophylaxis? There's no brainer in this. When will you stop it? If the CD4 count is more than 350 and there is no stage 3 or stage 4. Common sense. So if the CD4 count is more than 350 cells, and it has to be and, there's no or now, it has to be and, the person should not have no stage 3 or stage 4 HIV. Common sense. Why? Because you're talking of a lower CD4 counts. So this is what is the prophylaxis for pneumocystis jirovecii. Another point for you to note over here is what you have read over here is called as the primary PCP, primary pneumocystis prophylaxis. It is called as the primary prophylaxis. Why do we say it as a primary prophylaxis? Why do we call it as a primary prophylaxis? Because now you are preventing the pneumocystis carinii infection. Now we are preventing the infection. So you are preventing the infection. That is the reason we call it as primary prophylaxis. There is also a secondary prophylaxis. What do you mean by a secondary pneumocystis prophylaxis? What do you mean by secondary? See, if a patient already had a PCP infection. What is PCP? What do you mean by PCP? PCP stands for pneumocystis carinii pneumonia. That's an old name. Now we call it as pneumocystis jirovecii. So earlier name was pneumocystis carinii pneumonia. Earlier it was carinii. Now it is called as pneumocystis jirovecii. So what do we give in this? It's the same answer. No brainer over here. It is same answer. Double strength. The cotrimoxazole, that is the TMP SMX tablet we have to give. This is given for 3 weeks. So provided the CD4 count of this patient is, even if it is 350, more than 350 cells, even then it has to be given. Please note that the double strength TMP, same answer, has to be given for 3 weeks. That is called as secondary pneumocystis prophylaxis, and the primary is that you prevent the infection at the first place. So please note, just to summarize all the prophylaxis for you in a single screen, I have made post-exposure prophylaxis for HIV, cotrimoxazole preventive therapy. This is called as the CPT prophylaxis, that is for pneumocystis infection. And then you also have the isoniazid preventive therapy, that is for preventing tuberculosis. So that is the IPT prophylaxis, the CPT prophylaxis, and the PEP prophylaxis. What is the drug of choice for PEP prophylaxis? Please say with me. It is you're going to give the tenofovir, lamivudine, and dolutegravir. Next in line is what is the CPT prophylaxis? Say with me. It is double strength of cotrimoxazole, and that is double strength of trimethoprim and cotrimoxazole. Trimethoprim is 160, and sulfamethoxazole that we give is 800 milligram. Next is when do we start this TMP SMX double strength? Please note, if the CD4 count is less than 350, when do you stop it? That there should not be any stage 3 or stage 4, and the CD4 count should be more than 350. In case of isoniazid preventive therapy, that is for tuberculosis, we give to all HIV cases. They will receive isoniazid at the dose of 300 milligram tablet plus pyridoxine. They will all receive isoniazid plus pyridoxine. Plus, please note, there is a rider over here that the person should have ruled out TB. So all children with more than 1 year after rule out TB, all children, people living with HIV, you have to rule out TB. You do not give isoniazid to people with tuberculosis. You treat them. Are we getting it? We already discussed this in detail in your TB program. So also that this IPT prophylaxis, I would also like to add over here that the IPT prophylaxis, it is contraindicated. It is not given in case of tuberculosis in HIV. It is also not given. Please note that IPT prophylaxis will also be not given in case the person has hepatitis, or if the person is MDR contact. Any MDR contact will never be given isoniazid prophylaxis. So that was all regarding all the types of profile access that you were supposed to know for your exam. And in the next module, we are going to talk about other strategies under the NACO program, the organization, and the indicators.